This is a diabetic foot patient with a non-healing ulcer at the heel that had a stent placement in the popliteal artery 10 years ago that got re-occluded. All three below the knee arteries were occluded as well, and there was only late filling of the tibial posterior artery. We tried to cross this occlusion with conventional techniques with the help of a Bernstein catheter and a 3-5 guide wire, but unfortunately were unsuccessful, also because the subintimal pathway or retrograde access was unavailable to us. So we had to resort to something else. So we use the Battering Ram technique, and this technique consists of insufflating a balloon proximal to the occlusion, and this balloon not only adds a lot of support for the stiff back tip of the guide wire, but also keeps the tip in the middle of the plaque, so it allows for a centralized pounding for cap breaching. So this is how it worked out. We insufflated the balloon proximal to the occlusion. Only low pressure was used because only low pressure allows for the continuous pull and push of the tip of the guide wire. We used the stiff back tip of a zip guide wire, which is obviously not designed to be used inside an artery, so care has to be taken to not perforate the arterial segment. But once the cap is breached and a tunnel is created, we do an exchange and only use the floppy tip to gain access to the patent distal vessels. So the rest of the procedure is pretty standard. We dilated the stenosis or the occlusion inside the stent with increasingly larger balloons. Obviously in the below the knee arteries there still remains a lot of work to be done, but at least for the popliteal segment we were able to restore the inflow of the below the knee arteries by dilating and adding another supera stent proximal to the older occluded stent. So in conclusion, the Battering Ram technique is a last resort recannalisation technique for very difficult to cross occlusions. It should only be used in straight arterial segments that are preferably calcified or scaffolded by an older stent to prevent perforation, and the technique consists of insufflating a balloon proximal to the occlusion to provide additional support, but also for centralisation purposes. And we use the back tip of a conventional guide wire for maximal stiffness.